Okay, so now as we move towards the final section of the afternoon, we're going to up the tempo a bit, and we're going to hear from 9 next-generation researchers from MMV partner countries to do some lightning presentations of their research. So if I could ask them all please to come up and join us on the stage. Great. Everyone here? Okay, so first up, we're going to go to Dr. Roxana Ahmed, who's a consultant epidemiologist in Jakarta, in Indonesia, and a founding member of Clinesia CRO. She's done a lot of research in the control of malaria in pregnancy, and she's passionate about helping mothers and babies live free from malaria. And today she's going to shed light on her most recent study in Indonesia involving women with malaria early in pregnancy. Roxana.
Thank you. Madula is in her early pregnancy and she has malaria. Like Madula, there are millions of pregnant women living at risk of malaria. If they do not get proper treatment, they face grave consequences. The woman could die, or have a miscarriage, or stillbirth, or a baby with low birth weight. Does this have to occur at a time when we have safe and effective treatments for malaria in pregnancy? That's why malaria in pregnancy is important to me. Being a pediatrician and an epidemiologist, I am keen to contribute to the cause of defeating malaria. That made me go out into the rural communities in Indonesia, where my colleagues and I have been looking at the safety of drugs for treating malaria. First trimester malaria is like a fork in the forest, with the bushes challenging the treatment options. One tick path is the quinine way, which is the drug currently recommended by World Health Organization for treating malaria in pregnancy. Yet, it has low efficacy and is poorly tolerated. The other option is the artemisinin path, the path less traveled. Why are we afraid to go beyond the bend of the artemisinin path? Because animal studies have shown when artemisinins are given early in pregnancy, it harms the unborn baby and may increase the risk of miscarriage, stillbirths, or congenital anomalies. In Indonesia, we reviewed a decade of medical records and looked at pregnancy outcomes among 1,000 women who received the drug dihydroartemisinin piperacin and quinine to see the outcomes. We found there was no difference in the risk of miscarriage or stillbirth among women between the two treatment groups. We also followed up 50 women who received dihydroartemisinin piperacin in first trimester, and none of them had an adverse pregnancy outcome or a baby with congenital anomaly. This adds to previous evidence that artemisinins are safe for first trimester malaria. So we come back to the fork in the forest. The path is clear. The road is paved for artemisinins, and we can safely travel in the journey to eliminate malaria. I invite all of you to take a bold and brave step to advocate the use of artemisinins in first trimester. That would help the millions of medullas and their babies to live free from the harm of malaria. Thank you.
Thanks very much. And now Dr. Armand Guiguemde, who grew up in Burkina Faso and experienced malaria firsthand, and he now works as an investigator with the Novartis Institute for Tropical Diseases, and he'll share recent progress made by Novartis towards a new anti-malarial drug, as well as innovative strategies for the future of malaria drug discovery.
No child should die in the dawn of life. This is a quote from an American actor and philanthropist, Danny Thomas. He built a pediatric research hospital in the United States in the 60s. I first heard about that quote when I was visiting actually his hospital after my PhD, being interviewed for a position to work in his hospital. And actually, that quote was one of the motivations I joined to develop antimalarial medicines. And the second reason was being mentored by Kip Guy, a team working under his team, and also in collaboration with MMV, we're about to develop actually a molecule in a clinical trial. As a scientist currently at Novartis, my research is really to understand the biology of the disease and come up with ways to develop new medicine. What you see in this image in green are labeled parasites within a red blood cell. These green dots are the enemy. These are about to burst that red cell open and invade neighboring cells. Unfortunately, this is what drives the symptoms of malaria, starting with anemia, which can actually go to death if left untreated. The exciting part of my current research is leveraging artificial intelligence to develop new medicines. With the huge amount of historical data, we are now in a position to develop algorithms and also teach computers to predict actually antimalarial molecules. I believe that artificial intelligence has the potential not only to make drug discovery cheaper, make it faster, but also make more efficient molecules. Today, I'm excited to be part of a team that developed a medicine that's currently treating patients as part of the clinical trial. What you see here is ganaplacide, one of also molecule developed in collaboration with MMV, that was led by Thierry Diagana at the Novartis Institute of Tropical Disease. I'm really hopeful that this set of molecules will be able to impact significantly the effort toward malaria elimination. I would like to end with an aspiration and actually hope that all the work that we've been doing and been part of really will actually come to a malaria-free world, a world where kids really can grow malaria-free and be able to have the opportunity to grow and impact the world in any way they would like to. Thank you.
Thanks. And so now Dr. Rella Manego, who trained as a medical doctor and is currently working in malaria in pregnancy and anti-malarial drug development. And she'll share one of the social programs created by Carmel Malaria Research.
Seven years ago, when I worked at the emergency department of General Hospital in Libreville, I was really frustrated because the work environment didn't allow for the diagnosis and the treatment of patients with malaria coming in. We should know that the prevalence of malaria in Gabon is around 15%, which means 1 child every 2 has malaria. When I started working at Samby, the work environment was very different. I was able to diagnose and treat subjects with malaria coming to the research center. I particularly remember the case of this family of 4 people. The young mother, Sandra, aged 32 years old, coming from a village located 50 kilometers away from research center, with her 3 children, aged 7, 5, and 3 years old. The children has a fever for almost a week. The mother, Sandra, explained that she could only find the money for the transportation. Her husband works in another city and returned to the village at the end of the month. After examination, I performed the biological and microscopical analysis and confirmed the diagnosis of incomplicated malaria in eldest children and severe malaria with anemia less than 5 grams of hemoglobin per deciliter. Naturally, we add tablets to treat the eldest children, but for the younger children, blood transfusion was necessary. I went to my boss's office and explained the family situation, and she answered that as long as we will have money for the research, we will treat all the patients with malaria coming to the research center. So I went to the financial department to have money and transfer the family to the hospital. 4 days later, the family was discharged, and I could see the first time the youngest children smiling. This kind of program has been put in place and maintained because there is a company like MMV which invests in the malaria research. Please continue to support the research, continue to support the research center as malaria saves lives. Thank you.
Thanks. I should have said Rella is from Gabon. And now we're going to move to India and hear from Dr. Kiran Deep Sam, a medical chemist by training who spent 16 years in the pharma industry before moving into a public research institute and ultimately to MMV, where she leads its open initiatives via the Malaria Box, the Pathogen Box, and the Pandemic Response Box. And she'll present now on how MMV is supporting research not only in malaria but also other tropical diseases through the Open Access Initiative.
Good afternoon. So this is how traditional drug discovery worked in various research organizations. Limited access to data to the outside community, but during last 1.5 decades or so, new methods of working have been identified. And open science and open innovation is one of them, and call of the day. Now, MMV has been a strong supporter of open access to data and compounds. And working on such thoughts, and in line with this, an idea was conceptualized: why not provide the community a set of compounds, malaria-active compounds, which can be used to further enhance their understanding of malaria biology. So was born the idea of Malaria Box, and you can very well imagine the kind of response it received, because till now it was the first time the researchers had access to such kind of a compound collection. And during the course of project, more than 250 boxes were shipped, and we had to over 30 countries. And the impact was equally huge. The compounds were profiled in more than 500 essays, more than 60 publications. And in respect to understanding the malaria biology, almost 100 compounds were identified with probable mechanism of actions. And some of these compounds were then funneled into malaria drug accelerator to deconvolute the target. Not only these, cross-screening of these compounds against different pathogens actually helped in identification of new starting points for various drug discovery programs in other neglected tropical diseases. But this set us thinking, and what we realized that there is a huge appetite of compounds if they are not commercially available, and researchers are more than happy to profile these compounds in the assay systems which they are working on. And hence, MMV is at the forefront of collaborations and with new partners, and is committed to neglected disease research. So was born the idea of pathogen box, again a set of 400 compounds, with compounds active against at least one of the neglected tropical diseases, and more recently, pandemic response box to address the issues of antimicrobial resistance. In addition to top up these compounds, MMV regularly screens, profiles the libraries to identify new starting points for malaria research. And these compounds are also shared with partners so that new starting points are identified for other pathogens in addition to malaria. Until date, more than 2 million data points have been generated against different pathogens. And one such example where we can see how MMV has supported research in areas other than malaria is that recently Merck has promised to develop a compound which had its origin in these libraries and was being worked for schistosomiasis. Not only this, it clear-cut shows that how innovative idea, even at a modest funding, has an opportunity to become a wide worked upon idea with a huge impact, which goes not only in malaria, beyond malaria as well. And I request the audience present over here to support such innovative ideas, which have an opportunity to disrupt how we find solutions to various healthcare challenges. Thank you.
Thank you. And now, Olivia Guru from Cameroon, who's led the Malaria No More programs for Cameroon and for Africa, trying to keep malaria high on national agendas and rallying stakeholders to the cause. So she's going to talk now about efforts to continue to keep the world mobilized and finish the job to beat malaria once and for all. Olivia.
Thank you very much. So unfortunately, I'm not a researcher, but as a malaria advocate, we take any opportunity we have to pass our important message. So thank you very much, MMV, for having us. And I just want to talk to you about what we are doing right now on the ground in the fight against malaria. So I live in Cameroon, and I had malaria several times. But unfortunately, and fortunately, I was always able to get quality treatment. But I know a lot of people who are affected by the disease, and I know what this disease can do. So for this reason, it's important that we accelerate the fight against malaria. We saw the progress that were made during 2000 and 2015, leading to the reduction of 50% of mortality, child mortality, for malaria, which is thanks to the work of everyone here and others. But we also know that there are high risks that we are facing today. We know that there are issues with resistance, we know that there are issues with fake drugs, and also there are issues with access still, because we do have a lot of communities and a lot of people who still don't have access to quality malaria services. So for this reason, we believe that it's very important to involve community actors as not only as service providers, but mainly as actors and decision makers, and people who can actually be involved from the implementation phase to the monitoring and evaluation phase, but also support the national malaria control programs and partners to make critical decisions. So community health workers who are on the ground, who are actually the frontline workers, and who are able to reach the patients who needs malaria services critically, needs to be more involved. So for this reason, we have joined forces to create the first global network of civil society organizations, local African NGOs, community actors who are advocating for malaria programs that are people-centered, that are gender-sensitive, that are human rights-based, that are fully funded, and most importantly, that are sustainable. So we are looking forward to continue to advocate to our own leader to increase resources for malaria, and also to all of the partners to involve these actors to make sure that they can contribute to the data collection project through community-based monitoring project, because we believe that there are a lot of people out there that needs to be reached, and we have a lot of data that can be shared from those community health workers. And just an example, in Cameroon, for example, community health workers were able to report 70% of simple malaria cases. So if we didn't have them on the field, we will miss 70% of malaria cases. And they are not even yet in all the districts where they need to be. So my message was just to get all of us to continue to support community system strengthening and also community health workers, because they are doing an amazing job, and we think that is what is needed to accelerate the fight.
Thank you. So now Nina Brunner, PhD candidate at the Swiss Topical and Public Health Institute, who's exploring treatment-seeking patterns of children under 5 with suspected severe malaria in more remote regions. And she's very interested in closing the gap between theory and practice, between the intervention promise and the implementation problem.
I am Swiss, and I truly love bread. So when I was living in Uganda, I wanted to make this Swiss traditional bread called Zopf. However, because my friend only had an oven with heat coming from the bottom, the bread ended up looking like this. What happened? I had all the ingredients, I had all the know-how, but the context was not ideal. It was not as standardized as it used to be at home. I think many of us have seen the same happening to malaria interventions. Interventions that have been proven efficacious in a clinical trial under standardized conditions did not deploy their full potential in a non-standardized real-life context. In other words, they were not effective. John Reeder, the director of TDR, says what we need to make malaria interventions more effective is implementation research. I am investigating the implementation of rectal artesunate, a pre-referral drug administered by community health workers to children with severe malaria. Under ideal conditions, this drug, as a single intervention, can reduce the mortality of children with severe malaria by up to 50%. In real life, the success of this intervention will depend on many factors that are often contextual. Our study covers a rural area in Uganda and a remote area in DRC. The two places are different in many ways, but one of the most obvious differences is the number of community health workers providing RAS. In Uganda, there are 100 times more community health workers than in DRC for a similar sized population. That difference is almost like black and white. Because in DRC, community health workers fill the gap where no other healthcare providers are present. They receive twice as many doses of RAS compared to Uganda. In Uganda, the closest healthcare provider is always a community health worker. In DRC, it might be a low-level facility. This is why the extension of the implementation of RAS to primary facilities is much more important in Uganda than in DRC. The number of doses a community health worker receives, and the level of healthcare provision offering RAS, this is not something you are ever going to find out in a clinical trial. However, context cannot not always be categorized in such a black and white fashion. I want you to picture context as at least 50 shades of gray. I am not talking about the book. I'm talking about this, and then please add a lot of color. And that's also really what fascinates me about malaria. Controlling and eliminating it is super complex. There will be no one-size-fits-all. But if we pay attention to implementation, eradication of malaria is achievable. And I am sure we are going to make it. So, what advice would you give me the next time I'm going to Uganda and want to make bread? To tell my friend to get a new oven? No. I will just make a bread with a hard crust. it is not the context that needs to adapt to us. It is us that needs to adapt to the context. Thank you.
Thanks very much. Now, Dr. Daniel Yilma from Ethiopia, who's been conducting infectious disease research for over a decade at Jimma University in southwest Ethiopia. And he's going to talk about what to do with discoveries around drugs and diagnostics to reach the most affected and the hardest to reach.
I'm the third child in my family, but I found myself as a first when I was born. My family lost my two elder brothers due to febrile illness, but not sure if it was due to malaria. But I had myself occasions of febrile illness, and that scared me and my family, and was diagnosed finally with malaria. And I was provided with oral medication. But on the next day, my fever continues, and I was taken back to the hospital. And I was provided with, the physician informed us that I had severe malaria, and I was provided with injectable antimalarials. But now you see me here in front of you fighting against malaria and saying malaria elimination work starts with me. As one of our colleagues from Zambia, Elizabeth, said, lack of access, easy access to care is still contributing for malaria deaths. Some families should travel a longer distance to get the care. Ethiopia had significantly reduced malaria deaths by only giving or increasing the accessibilities by training non-health professionals in the community to diagnose and manage malaria. This enables families to get care directly. But this can be strengthened and become more feasible if we can develop a simplified diagnostic and treatment tools. I've been working as a principal investigator on two single-dose drugs, one for relapse prevention and the other was for cure. This is one way of simplification of the treatments, and especially if it is less toxic and also it is child-friendly. Such kind of efforts makes me much optimistic for future malaria elimination. Recently, I met one of the clinical participants in malaria relapse prevention, and while he was in his job, and he told me he is at his current job because he participated in the trial. This participant had recurrent malaria since he was a child, and when he goes to the college, he have almost 2 or 3 times recurrence. That is every 2 months, 3 months times in a year. And he was to discontinue his education. By participating in the trial, he was lucky that he was able to get relapse prevention arms, and he continues his education and finalize. Ethiopia is not providing relapse prevention treatment because G6PD tests should be done before the treatment is given for hemolysis. And the G6PD test is a very costly, and it is a complex, and it needs highly trained personnel. So point-of-care tests should be available. And currently also we are working with past teams on point-of-care tests for G6PD, so for radical cure treatments like Tafnoki. So we need more strong efforts towards malaria elimination, the policymakers, industries, and scientists to make a simplified treatment and diagnostic tools. I hope with such kind of efforts, we'll see in the near future that no student will be absent from school and no deaths will be reported. Thank you.
Thank you. And now Dr. Jane Achan, who's coordinator of the malaria group at the Medical Research Council unit in the Gambia at the London School of Hygiene and Tropical Medicine. She's a child health advocate. She's passionate about infectious disease control and elimination. And for 18 years, she's been working actively with a focus on control and treatment in different risk groups.
Thank you. So as a practicing pediatrician and a mother of two, malaria is very important to me because it causes a lot of sickness and death. In the hospitals where we work, 6 out of every 10 children we see has malaria or one of its complications. Sadly, scenes like these are far too common. Effective malaria control interventions are available and include things like insecticide-treated nets, indoor residue spraying, case management, and preventive treatment. These interventions need to be implemented to scale to ensure that no intervention coverage gaps exist. Why is this really important? If we equate the current high burden of malaria to this pool of large body of water, we know that current control interventions have achieved a significant reduction in the burden of malaria. However, if the control interventions do not optimally cover entire populations, we have pools of high transmission that remain. It's therefore critical that these remaining pools of infection are cleared if we are to achieve eradication. One of the well-known strategies that has been used uses the anti-malaria drugs to reduce transmission in the community by clearing the parasites in affected populations. My current research actually does focus on mass drug administration, or MDA, to clear remaining pools of malaria in the eastern part of the Gambia. We are currently evaluating the impact of MDA using 2 drugs, an anti-malaria drug, dihydroartemisinin and piperaquine, and a mosquitocidal drug, which is ivermectin. Now, these 2 drugs work synergistically, they work together. The anti-malaria drug clears the parasites from the infected red blood cells, and the mosquitocidal drug actually has a killing effect. It kills the mosquitoes. This synergistic effect leads to less parasites in circulation, but also reduced mosquitoes in the communities biting the members of the community. We have had some challenges in implementing this intervention. Some community members do not accept the medication, and some places are also very difficult to reach, especially during the rainy season. But with community sensitization and well-coordinated field activities in collaboration with the Gambia Malaria Control Program, we have been able to achieve more than 80% coverage across the different villages. We hope that we will be able to demonstrate a significant reduction in the burden of malaria and hopefully achieve zero transmission in the communities that we are working in. So I believe the goal of malaria eradication for good is achievable. The current control interventions we have actually do work, but they need to be implemented to scale. In addition, I urge all of us here to invest in the development of additional innovative approaches, for example, MDA. Together, we can reduce the pools of malaria transmission and achieve malaria eradication. In so doing, save many lives like this. Thank you very much.
Thank you. And lastly, we're going to turn to Dr. Carolyn Aguiar from Brazil. She's a postdoc at the Center for Innovation in Biodiversity and Drug Discovery at the University of São Paulo. And she'll be talking about accessing blood samples from infected patients to understand if new drug candidates will work in real life.
So, my interest on malaria disease started during my master's degree. I was working in a lab in a non-endemic area of Brazil, doing basic science. At that time, my lab was helping some hospitals of my city with the diagnosis of malaria suspected cases. So, I had the opportunity to look this image into the microscope. This patient had almost 40% of their blood cells infected with Plasmodium falciparum, the most lethal malaria species. He arrived from an endemic area, and after 1 week, the malaria symptoms started. But unfortunately, he was not diagnosed on time, and he died. That day, I understood the importance of malaria disease. And I decided to do something to help to change this scenario. That's why I started to work at this research center, located in the Brazilian Amazon region. At this place, we have a lot of vivax malaria cases and some Plasmodium falciparum cases. And nowadays, I can say to you that I'm doing my best contribution to help the fight against malaria disease, in collaboration with this amazing organization, Medicines for Malaria Venturi. Together, we are a center of excellence to test new compounds against Plasmodium falciparum and Plasmodium vivax field isolates. In this so exciting project, we put together the blood that was collected from infected patients with the promising new compounds. Our main focus is to figure out if the new compounds will kill the malaria parasites that are currently infecting people in the endemic areas. This project is so important, in my opinion, for two main reasons. The first reason is we can understand if the new compounds will kill vivax parasites. This is the only way to answer this question, because you have no way to continuously grow these parasites in the laboratories. So we need to have access to the blood forms of infected patients to answer this question. And the second reason is, this is a kind of a proof of concept, and you can understand if what works in the laboratories can work in the field. So, considering that every 2 minutes a child dies of malaria disease, for me, leave the non-endemic area and start to work close to the people that is suffering from this disease is the best way to include a piece of the puzzle to have a happier humanity. Thank you.
So it's been great to hear such a wonderful collection of energetic, passionate, younger researchers from so many different countries of so many heights. Great to see so many women researchers as part of this, but all of them committed and united by a kind of common passion and goal around tackling malaria. So do please give them another round of applause. Great.